Good morning, all. At the outset, I would like to thank Dr. Archana ma'am, uh, Dr. Rajnikant for having me here. It's a nostalgic feeling. I still feel like I'm a student. I still remember the day I entered this place, and this has been a great place. And whatever I think majority would be of due to this place, and I owe this place so much. And I would also like to acknowledge people who trained me, of which the main mentor is sitting there, Dr. Bajal sir. I think Archana ma'am was the most friendly person at that point of time, I remember. So we used to go and talk to her regarding any issues, and she was the most cooperative person. And again, though they were my co-SR, but they were my teacher as well. Dr. Gaurav Luthra and Dr. Amit Parihar. I would like to mention them because my first posting in DSA, that was my second month of my SRship over there. And they taught me how to puncture, how to do initial angiographies. And I really owe everybody a lot. Institute has given me so much. I won't be ever in a position to repay it back. So coming to the talk, so I'll be talking about mostly retrograde obliteration consisting of BRTO and PARTO and how it all happened all throughout the years. So I have nothing to disclose. And at the outset, I would like to start with this wonderful paper which came in 2018. Though I started the work in 2011, but this gives me, some evidences like what I was doing. So this came up in 18, but we thought it way back in 11. So this paper talks about association between photosystemic shunts and increased complications and mortality in patients with cirrhosis. And it was a multi-centered European trial consisting of almost 18,000 patients. So what they say that patients with spontaneous photosystemic shunts, if we talk all patients had chances of more hepatic encephalopathy, but those patients who had middle of just 6 to 9 or child PUA, they also had more complications and mortality. So any patients who has a shunt will have complication. And this is from gastroenterology impact factor more than 20. So, you and 18,000 patients data. So this is very important. So what we conclude that in patients with preserved liver function, SPSS identifies patients with a higher risk of worse outcomes. So that's most important. SPSS outcome poor. We need to remember that. So with this, I'll set the ball rolling and coming to anatomy of the collateral pathways. So this is how it happens. The most common is you may have left gastric, you may have posterior gastric or short gastric, which may come from the perigastric region and form a gastrorenal shunt through adrenal vein. It may have a perforator, which will form a gastric varices, may not have a perforator. Then some of them, which is not very common, they may form the shunt through the gonadal vein. And finally, some may form the shunt without anything. So the adrenal and the gonadal vein would be separate, but still they may form a shunt. Then what is the variations at the confluence at the renal vein? So it may directly have a single shunt coming into the renal vein. It may have two shunts which bifurcate and then again join before entering the renal vein. This is known as a ring type. And then there is a streak type where you may have a single shunt coming and they multifurcate and then they meet the renal vein at different locations. So showing you some of the examples, here you see there is a gastrorenal shunt and there is a perforator through which we see the varices going inside the lumen. So these are gastric varices. Then these are paragastric varices with no perforator, no gastric varices. These are just shunts. So will cause only hepatic encephalopathy. And this is how you treat them. You can come from femoral or jugular aspect. Then you may have a ring type. Here you can see there are two veins which are forming, one here. And for this, you may require two axes, maybe from the jugular side, femoral side. Here we took one axis from the jugular, femoral, and the ring type has been closed. And these are some of the initial cases which we did way back. Then we have another splenorenal shunt where the shunt is distal in the renal vein And the adrenal and the gonadal vein is separate. Then you have a splenogonadorenal shunt. You can see this is the gonadal vein. If this is much dilated, this is how it is forming the shunt. And if you see, so this is the gonadal and this is the gonadal and this is the splenorenal shunt. So you have to embolize both these shunts. So one plug is here, the other plug is here, and you can see this is embolized over here. And then maybe there may be a right mesogonadal cable shunt. You can see how it is. It is the mesenteric vein, the superior mesenteric vein, and jumbled up collateral over here, and how it meets. So this is the right gonadal vein. And apart from it, you will have some of the collaterals may meet the IVC directly. And again, for such kind of shunts, you will require to embolize both. So one plug is there in the gonadal vein, the other is in where it meets the cable. So cable shunt, and both are embolized. And if you see this image, both is embolized. These are the sclerosing agent and totally gone. So the previous jumbled up image where we saw is totally gone. So what we understand that recognizing these collateral is important because they may lead to variceal bleeding and hepatic encephalopathy. Occlusion and obliteration of these shunts may help in managing gastric varices and treating shunt-related encephalopathy. And understanding their anatomy helps in planning and intervention and avoiding complications. So this is what we understand with the initial paper, which I said. So now just quickly talking about my journey and understanding this SPSS. So it started in 2011. I joined ILBS in January 2011. And the first referral which I received was in April 2011. I had never seen this procedure, never heard, though we discussed this procedure in SGPGI. In fact, Dr. Bajal was the moderator, discussed this thing, and we did know something about it. So, and we knew that it is for GI variceal bleed, but hepatic encephalopathy was a new indication. I never knew that it can be done for, but since my director, Dr. S.K. Sareen, whom I owe very much, he was insistent that you should do it. So I again went back, read some article, but it was all on gastric varices. So we decided to do. So what I had with me, so it was details of technique as I had read in the article. So definitely article gives you some overview, but and patient and CT image, definitely there is a patient, there are CT images. Willingness, yes, I was willing. So I wanted to prove something, some basic hardware. So these were the hardwares which were available. So a basic sheath, what was available, a normal angioplasty balloon that was available, some sclerosing agent, normal catheters. So this is what we had. What we didn't had. So whatever was described in literature, the hardware, we had nothing. Nothing was available in India because none of the commercially available company in India were making. In fact, later I realized that those hardwares which were mentioned, they were only available in Korea and Japan. And even today, they are not actually available. There was no experience. So, personally, nobody had an experience of this procedure. So actually, since there was no experience from India, there was no one to guide. Then again, because of all willingness and we started, this is how we did our first case. So if you see, this is the normal angioplasty balloon. We were into the shunt. We were somehow able to occlude it. There is an aneurysmally dilated shunt, and we can see it go that contrast going there. And this is the picture when we wanted to deflate the balloon. We came out. At that time, we were very scared whether the renal vein is thrombosed or not, but renal vein was patent. And we were very happy to see that there is some sclerosant which was staying there after that. So very happy. And there was improvement in patient's clinical symptoms. So that was the most gratifying. But when we did the CT scan, we saw that the only aneurysmal part was thrombosed. And the confluence of the renal vein and the shunt, there was some narrowing of the confluence, but the shunt was persistent. This is what we saw. But the patient, because it was a HE patient of hepatic encephalopathy, patient did well. So we got our second case. Second case, again, we started and we were very lucky this time. Again, same balloon. So the hardware remains same. First case, successful. Second, again, you think, okay, I have, I have all the tricks to do it. And we again use the same balloon. And this time we were able to send all the sclerosant up to the gastric varices, and it was for gastric varices. Again, lucky. Next time, into the gastric varices, completely embolized. Third BRTO procedure. And here the problem started. Again, we took the same hardware, and this time we were very confident. Yes, we can do it. Why nobody was not doing it? And then we realized why nobody was not doing it. You can see this balloon, and it had actually, ruptured one of the small venous channel. We see a lot of extravasation over here. So we again kept the balloon there, waited for it to thrombose. The patient was clinically stable, and gradually we deflated the balloon. Patient had a lot of pain, but we gave him antibiotic and other, conservative treatment. Patient did well. Clinically also improved, probably because there was a lot of hematoma over there. It compressed over the shunt, and clinically patient did well. But we were very scared. We were not happy taking a fourth case. So fourth procedure, we again went looking for hardware, change in hardware. So this was the fourth case, and this time we got some hardware. So we got a Schwann-Ganz catheter, and this was the Schwann-Ganz catheter compliant balloon, and this worked very well for us. Again, we were stuck because the size of the Schwann-Ganz catheter was hardly, it can be inflated up to 12 millimeters, something like that. And you can't use it for shunt bigger than 12, 13 millimeter. As soon as you inflate it more, it will burst. These are compliant balloons. So then we went again to endoscopy suite. They have certain balloons where it can be inflated, and they use it for extraction of stones. So it is known as a stone extraction balloon. That's again a compliant balloon. So that goes up to 18 millimeters. So that was our third. And finally, then we moved on to CODA balloon and other balloons which are used in AAA devices. Those are again compliant balloons available. So we understood that you can take femoral or jugular route, because what was described was only femoral route, but sometimes it is very difficult. So we thought that probably whenever required, you can take a femoral or jugular route based on anatomy. You should always use a compliant balloon, and you should oversize it, because in some of the cases we saw that after pushing some contrast, when the vein was distended, you see some of the sclerosant coming back to your sides of it into the systemic side. And this is what we made the cocktail-like STS with lipidol and air. But again, lipidol caused a lot of problem. It used to sclerose the balloon wall because these were compliant balloon and they used to rupture. But anyway, we were enthusiastic. We kept doing it. And this is our first paper. We started in 2011, 2012. We were able to publish in JVIR. And it was just data of 7 patients published as an original article. And we proved that it is a good treatment for therapy and it works well. Second, data of 18 patients, we presented it in RSNA in 2013. So another year, we added another set of 11 patients. 2016, we had 61 patients with 63 sessions of BRTO, and this was in CVIR. And this was later in European Radiology, where we published a long-term outcome up to 7 years. So you can see 1, 2, 3, 4, 5, 6, 7 years HE-free survival. So gradually we kept progressing, like we didn't stop. And then we realized that how it happens. So there is a very good HE-free survival. This is our paper. And overall survival was also pretty good over here. And we concluded that BRTO is a highly effective procedure for shunt-related hepatic encephalopathy. And patients with preserved liver function show a better post-BRTO outcome. More so, the liver synthetic function shows a definite improvement. So it was not only controlling hepatic encephalopathy and gastric varices, but the liver synthetic function was also improving. And that happened because you are making a hepatofugal flow, a hepatopetal flow. You are forcing the blood to go towards the liver. Actually, all the gut hormones should reach the liver, which was bypassing the liver. And we also got to know that CTP score is the most important predictor. Before that, it was said that those patients who was not eligible for TIPS, and especially CTP-C patient, can get BRTO, but we saw that no, even if you go for a patient who has advanced liver disease, if you do a BRTO, there are chances of liver failure in those patients. So BRTO is not safe in patients where advanced liver disease is there. And that was a myth which was thought previously in 2010 era. Then we started working on gastric varices, which was the actual indication for BRTO. And, you'll just quickly show you some of the images. These are for gastric varices. You can see all these varices are totally gone over here. And again, we published our data. And it was again very gratifying to see that, the data for BRTO is also lagging. It's still, apart from APASL guidelines, that is the Asia Pacific guidelines for the study of liver, even European guidelines, Bavino, as well as ASLD, they still don't have BRTO as a first-line treatment for uncontrolled gastric variceal bleed. So that's important. But as for APASL is concerned, that is Asia Pacific, we have this because the Asian people believe that BRTO is a better therapy. And this is how you see what happens to the CTP score. You can see the CTP score is much higher before BRTO. And as you do, they start coming down. MELD score similarly improves. Albumin goes up. So albumin improves. So overall synthetic function improves. But BRTO definitely had its own issues and difficulties, like the procedure time. The procedure time is 4 to 6 hours and sometimes overnight. We started doing it in the evening. We used to keep the balloon inflated, send the patient in ICU, call the patient back in the morning, and then deflate the balloon. But many times we found that the balloon was already displaced, but the balloon got, ruptured and something, and so on and so forth. Then this paper, a very, innovative paper came in radiology regarding PARTO. So this was a first paper describing a technique, plug assisted. So instead of balloon, they started using plug. So how this is done, you can see here a sheath is there. You can see a plug over here, vascular plug, and you see this thin thing. This is a microcatheter by the side of the plug. So you take your microcatheter first inside the shunt, and by the side of microcatheter, you place a plug. Plug is generally placed at the most constricted area so that you see a hourglass kind of a thing where the central part of the plug is not totally open, nicely opposing the wall. The upper two part is opened up, and then you start injecting gel foam slurry. Here at the first go, you don't inject sclerosant, you use gel foam because you want to block the interstices of the plug, because plug will allow everything to flow through it. It takes a lot of time for thrombosis to happen. So you have to inject gel foam slurry into it. Once the interstices are totally packed with gel foam, then you can use sclerosant to finally fill the shunt as well as the varices. So this is how you do. You come from the femoral, or you may come from the jugular side, cannulate the shunt. Then you can place a plug. You take your microcatheter beyond it. In fact, microcatheter is placed prior to the plug, and then you deploy the plug. And this is how it looks after the interstices are blocked. Everything fills up with the sclerosing agent. And this is the picture. When you remove it, you can see it's nicely blocked. And if you see the follow-up image, this area which was filled up with varices is totally clean. And this is how the gastric varices which were there is totally clean. You just see a normal gastric mucosa over there. But PARTO still is not the most simple procedure. It has its own challenges, like advancement of a large diameter long sheath. You need a long sheath for delivery of the plug, and that's one of the most limiting factor. There may be unfavorable anatomy, because I saw showed in initial slides, like anatomy may vary depending on how the varices form. So that may lead to failure of the procedure. And wherever if you fail by taking different approaches, then you are left with going back to BRTO, or there is another procedure called CARTO, where you use coils instead of a plug, or you may do an anti-grade shunt obliteration, like coming from the transhepatic side, transsplenic side, or accordingly you may try and cannulate it from other locations. So this is again what we studied, like how to go and understand the anatomy and take the advantage. Like if you know the anatomy beforehand, you can modify your procedure. So sometimes if you have a angle of the renal vein with the IVC like that, then you coming from the jugular would be preferable. Wherever it is more horizontal, femoral route would be preferable route. Similarly here, femoral route would be a better rather than coming from the top. And here definitely femoral route is the preferred route. Again, the distance of the shunt. If the shunt is closer to the IVC, then again femoral route is preferred. But if it is far away, getting inside and going into it may be difficult. So jugular may be preferable. Sometimes you may find a shunt coming, meeting the renal vein from below. So again, those are difficult. You will have to try which works. Maybe jugular, maybe femoral. And if there is an aneurysmal dilatation, then you are stuck. Probably your wire will keep making loops there, and it may be difficult for you to ascend, especially if the confluence is very narrow. Sometimes this confluence is very narrow, and it doesn't allow your wire to get and ascend inside the shunt. So it may be difficult. So you may just keep struggling. If you are lucky, you may go inside, but sometimes, so either you can call the patient for a repeat procedure. Sometimes calling the patient next time helps you out. You may try using different shaped catheters, but if nothing works, probably antigrade is the way. And again, we tried to study these factors, and we had this paper which came in CVIR, and different angles we talked about, different lengths we talked about, and based on it, we made certain protocols that you can see and follow, and accordingly that I have already discussed in my previous slide. So coming to recurrent gastric variceal bleed, if you see here in this endoscopic glue injection has already been done. If you see this black area, this is the glue cast which is seen over here. And this is the portal vein. So if you see the portal vein, because everything is being shunted out of the liver. So the portal vein and the hepatic arteries are essentially of the same size. And in fact, in this image, you can't even appreciate there is any portal vein over here. It's all sclerosed, and this is the vein. So we went inside, we did the PARTO, and this is the image. And this is the follow-up. You see all the varices which were seen before is totally gone. And this is gone. But what is important? Important is to note that this is the portal vein. This was the portal vein before, which was totally thin, atretic. And you see the portal vein over here. It is much dilated. Now you can see the difference between the artery and the portal vein. This is gone. And if you see the liver is much well perfused over here. If you see the left lobe, it seems slightly bigger. If you see here, the left lobe is thin. So this gave us another idea, and we did a randomized control trial regarding to see whether if these shunt occlusion is going to help in liver volume as well or not. And we found that definitely there is a change in liver volume. So if a patient is in a standard medical therapy group, that is the standard of care, then there is a reduction in volume. Like if in our patient, the pre-procedure volume was 988 cc, which came down to 904 cc. So almost 84 gram loss was there in 1 year follow-up. Simultaneously, in the shunt occlusion group, the pre-procedure volume was 1040 grams, which became 1132 grams. So if you occlude the shunt, there is increase in volume. But simultaneously, if the patient is left for a standard medical care, the volume will go down. And that's a very important finding, which I told, because gut hormones and the nutrients are meant to go to the liver and nourish the liver. So liver is devoid of the nourishment which it should get by bypassing the liver. So if in an early stage of cirrhosis, if you occlude these shunts, this will help in improving the liver volume. And at least, if not improving the liver volume, it will at least prevent any reduction in liver volume. And this is how albumin did. Ammonia, definitely, we knew from before that it will definitely improve. And MELD, again, there was a significant improvement in MELD. And this is one of the images showing how this was the best case, where the pre-procedure volume was 1209 cc and the post-procedure volume increased to 1641 cc. So what I learned all these years, that SPSS are formed in patients with portal hypertension as a decompressive mechanism. So it is a mechanism, it is just like a tips. So body does its own tips. SPSS in cirrhosis is associated with increased morbidity and mortality, secondary to gastric variceal bleeding, hepatic encephalopathy, and liver failure. Anatomy of SPSS and availability of compatible hardware is needed for successful performance of BRTO, PARTO, or shunt occlusion. Obliteration of SPSS by BRTO, PARTO is an effective treatment for gastric variceal bleeding, hepatic encephalopathy, and shunt obliteration also helps in improving the liver synthetic function, serum albumin, and improving the CTP and MELD score. Finally, liver volume in patients with preserved liver function. So those patients who have preserved liver function, that means CTP-A or early CTP-B, would have definitely improvement in liver volume as well. And with this, I'll end my talk. And again, my gratitude to Department of Radiology, SGPGI, all my mentors sitting here, those who are here and those who are not here. Thank you all.